Hello and welcome to this National Institute for Health Research seminar on Covid-19, a multi-system legacy. So my name is Elaine Maxwell and I'm content lead in the centre, and this is just one of a number of events that we're holding in support of our dynamic review, Living with Covid-19. And we are going to be recording this session and putting it up on our website for people to view in the future. So we're joined today for this discussion by three members of the steering group that helped us with our review. So we have Dr Philip Pearson, who's Consultant Respiratory Physician at Northampton General Hospital, Group Captain Alex Bennett, who's Professor of Rheumatology and Rehabilitation Medicine at the Defence Medical Rehabilitation Centre, and Dr Vanessa Abrahamson, who is the Research and Development Lead for Neurological Practice at the Royal College of Occupational Therapists. The way we're going to run this is we're going to have a couple of short presentations and then a panel discussion. If you'd like to suggest some questions that I could put to the panel, please do so using the Q&A box at the bottom of your screen, not the chat box, the Q&A box. Unfortunately, we won't be able to answer all the questions live, but we will look at them later and hopefully put up some more answers on our website. We are also going to do 3 polls so we can get some quick feedback from our audience. And if we could start with our first poll, we're trying to find out a little bit about who is on the call and what your interest in long COVID is. So if you could vote now. And that's an interesting finding. So we've got quite an even spread of people, mostly people who are either living with long COVID, health professionals working with people with long COVID, people who are interested in this, or others who I think are people from policy areas. So I think without any further ado, we should move on to our first presentation from Dr. Philip Pearson.
Good morning. Hello, my name is Philip Pearson. I'm a respiratory consultant from Northampton General, and I'll just do a little reflection on what we expected to see around the time of COVID infection and afterwards, and what we actually saw. So because I'm a respiratory physician, I am required by law to show you a chest radiograph. So this is the obligatory chest radiograph that I'm going to show you today. This shows a patient that we saw back in April, and the main abnormality here is sort of fluffy changes, alveolar shadowing on both the left and the right lungs, and this was a typical pattern for COVID infection. And at about this point, our thinking went something like this. It's a respiratory illness. It looks like adult respiratory distress syndrome. Hospitalized patients are obviously the more unwell ones. And because it's a respiratory illness, it looks like ARDS, we would expect post-ARDS pulmonary fibrosis. And this was supported initially by scans like this. This is a CT scan of the same patient contemporaneous with the chest radiograph, and this pale grey stuff is ground glass shadowing all through both lungs, and that is not normal. That's the relatively normal bit of lung just there, all the rest is not normal. And what we thought we were going to do was treat this like ARDS and attempt to extubate patients who went to ICU as quickly as possible, get them off ICU as quickly as possible. 3 months later, this particular patient was still in hospital. She has had bilateral pneumothoraces, so air leaks around the lung, and she's also got cystic changes within the lung as complications of the infection. And indeed, 6 weeks after that, she has now got developing pulmonary fibrosis, more obvious cystic changes within the lungs. And this is sort of what we were expecting to see. It's a lung disease, lung complications, and obviously the follow-up will need to be with a respiratory physician for these lung complications. But the other thing that we saw with the primary infection was thromboembolic complications, so blood clots in the lungs, but also in the guts, kidneys, in the brain causing strokes. Also multisystem complications, particularly affecting the heart. And the curious thing from the intensivist point of view was this wasn't behaving like ARDS. When you ventilated the patient, the settings that were required were not the same as standard ARDS. After the initial infection, it wasn't just a simple road to recovery. So after an episode of bacterial pneumonia, if a patient is admitted to hospital, you'd expect that they would have a progressive recovery over 2 to 3 months, but they'd probably get more or less back to normal after that time. Here, we've seen ongoing symptoms that are multi-system and conflict between systems over time. It's not just the hospitalized patients. And for that matter, there are some non-hospitalized patients who seem to be having worse ongoing symptoms. And the symptoms they're having, sorry, go back a step. We've seen what I think are probably four distinct clusters of patients and presentations. One is the ones with definite end organ damage, like the patient I've showed you. Ones with a post-intensive care unit syndrome, which is well recognized as a complication of being on ICU for a long period. Ones who seem to have a post-viral chronic fatigue-like syndrome. And then there are the ones who seem to have very different ongoing symptoms, which are many and varied. A brain fog is common, fatigue is common, sensory disturbance, chest pain and breathlessness, which is sort of what we were expecting, headache and encephalitis, which we weren't, skin changes, many, many, many more. And the other thing that the patients have been telling the NIHR group in particular is that when they phone the GP or when they phone other healthcare providers, they do not feel listened to, they do not feel believed, particularly if they phone up a healthcare professional and say, well, I think this is related to that COVID infection that I had some months ago. They're told, it can't be. It can't be, you're making it up. So what do we call this? There are various terms that have been suggested and used. The preferred one, particularly among the patient groups in the UK, is long COVID. In the US, it's long haulers. Some people have suggested post-COVID syndrome, but that sort of implies that you've had COVID and this is something afterwards. Chronic COVID, well, is there evidence of an ongoing infection? Post-acute COVID? None of these are entirely satisfactory, but that doesn't mean that there isn't a distinct group of patients that we can define, at least as in terms of the symptoms that they're presenting with. And at the moment, I think I'm left as a respiratory physician with more questions than answers. Are the risk factors for ongoing symptoms the same as the risk factors for mortality? Don't really know at the moment. What is the prevalence of this among the hospitalized cohort and among the non-hospitalized cohort? what is the prevalence and severity among NHS staff, because that has profound implications for workforce planning over the next 5, 10, 15 years. And also, what do we do with the patients who do have ongoing symptoms right now? Because one of my colleagues was telling me about a patient who he has seen, a older man, but previously fit and well and doing a manual job, who has basically not been able to function properly for the last 4 or 5 months because of fatigue and breathlessness. His lung function tests are essentially normal. His CT shows a little bit of pulmonary fibrosis. So do we treat this as a chronic fatigue-like syndrome and recommend rest? Do we recommend post-infection rehabilitation? Do we try steroids? What do we do with this group? And the final comment that I'll make is a question and a warning from the late Professor Oliver Sacks, who was a neurology professor in the States. And one of his observations was that in the US, if you want to quickly summarize examination findings in the medical notes, you can write WNL for within normal limits. But he observed as a neurologist that particularly the nervous system examination is not done particularly well. And very often in practice, WNL means we never looked. There's been focus on hospitalized patients and post-primary infection symptoms. There's not yet been an awful lot of focus on non-hospitalized patients. And my great fear is that WNL, we never looked, and therefore we won't find out what we need to know to help the patients who will be coming to us as healthcare professionals, to help advise them and treat them in the next few months and over the next year or two. Thank you. I will end there. And Elaine, back to you.
Thank you, Philip, for that. So just a reminder to the people who are listening in and those who joined us after we began, we're going to have a second presentation, and then we're going to have a discussion between our panel members. So if you'd like to suggest a question for me to put to the panel members, please put it in the Q&A box at the bottom of your screen. And now I'd like to hand over to Group Captain Alex Bennett.
Thank you very much, Elaine, and thank you, Philip, as well. Delighted to be here today. I'm, as Elaine said, Group Captain Alex Bennett. I'm the Defence Professor of Rheumatology and Rehabilitation at Stamford Hall, and in the next 10 minutes or so, I'm going to talk to you about the Defence Medical Services Covid-19 Rehabilitation, Recovery and Research Programme. And slightly contrary to tradition, I'd like to really acknowledge and thank my collaborators and team at the beginning of this presentation, because this has without a doubt been a huge group effort from everybody on the screen and probably many others that I've forgotten. But it's really important to acknowledge that, and I'm just the fortunate one who's here to present what we've done really over the last 7-8 months and some of our preliminary clinical and research data, but it is, to emphasize, very preliminary. So back at the beginning of the year in January, we watched with amazement as we saw this disease unfold from the 4th of January, which is an original Twitter from the WHO saying there's been a cluster of pneumonias in Wuhan in China, to just a couple of months later on the 11th of March, where they announced it to be a pandemic. And then 5 months later, after the onset, there's 6.6 million people with the confirmed disease. And then just yesterday, there was 47 million people and 1.3 million deaths. We, like I'm sure many of you, spent an exponential amount of our time looking at exponential curves. And we were wondering, what are we going to do about this? What are we going to do about it now? And what are we going to do about it if a second wave comes along? And this was a slide I prepared back in June. And unfortunately, it seems that the prediction on the top right-hand side is the correct prediction for the second wave, which is a bit worrying and keeping us all very busy. Initially, there was quite rightly a lot of emphasis on testing, and there still is. There was a lot of emphasis on acute care and also on severe disease. But it became quite clear fairly early on, and as Philip has already alluded to, that this wasn't just a disease that affected the cardiopulmonary system. It was definitely a multi-system disease. Also, it wasn't just an acute disease where you either got it and unfortunately died or recovered, but there was quite a lot of initially anecdotal evidence on Facebook and in newspaper reports, and then some quite good data, particularly from the COVID symptom tracker from Zoe and Professor Tim Spector, that this was actually a disease which had a protracted disease symptomatology. And what was very interesting, and again, as Philip has alluded to, this is not just in people who have been hospitalized or in intensive care. We were seeing this, or it was being reported in people who had had quite mild acute initial illness. So in defense, what we wanted to know about was we wanted to know about the unknowns. We wanted to know about how this disease was going to affect our population. And we wanted to know about the complications and outcomes in young active populations such as ours, in those who've had mild disease, and those who are required to undertake high levels of physical activity, as in our population, as part of their work. You may be thinking, why have we got a military person here presenting to us about military clinical outcomes and military research? And you may be thinking, well, everyone in the military is like this gentleman here, you know, extremely fit. Well, we do have some extremely fit people in the military, but we also have some people like this, and we have an awful lot of people in between, who actually, you know, from an age range of 16 to 60, a lot of them with a very moderate levels of fitness. I think our population is very relevant to large proportions of the general population. So what we started with was we needed to learn more about this disease, and back in April we worked very hard as a group to review all of the evidence, particularly from SARS-1 back in 2002 and MERS in 2012, and we look at all the evidence and also the emerging evidence from COVID-19, and review that evidence and draw up a consensus statement. This was very much a group effort, but it was very much driven by two of our excellent registrars, squad leader Rob Barker-Davis and Major Ollie O'Sullivan, who've done an excellent job with this. And we came up with a consensus statement, which was published in the British Journal of Sports Medicine, giving our consensus of 20 plus physicians and healthcare professionals from different areas on general pulmonary, cardiac, exercise, psychological, musculoskeletal, neurological, and medical rehabilitation. And essentially, we used this as our background for forming our COVID rehabilitation service. And that COVID rehabilitation service is at Stamford Hall, which is the Defence Medical Rehabilitation Centre near Loughborough, and has been there for the last 2 years. It previously was at Headley Court. So the COVID rehabilitation service, the first patients came in, I think, at the end of April, beginning of May. And really that's is formed around what we normally do here, which is multidisciplinary team rehabilitation. They start with a VTC initial consultation, which is clearly remote, and that's an MDT consultation with a consultant, a physiotherapist, occupational therapist, and exercise rehabilitation instructor. The patients get information booklets and a self-help guide. They then come in for a 2-week residential rehabilitation course. After that, they have a 3-month follow-up via VTC. And if they're having ongoing problems, they will often enter into our conventional viral fatigue program if they're still having issues. Here is a slide which is, I know, very detailed, but it's really just to point out to you that there was quite a lot of focus on education. I don't know if you can read this, I can only just, but we had education about the effects of COVID, about pacing, about returning to work, and about nutrition. There was also a focus, and these are just examples, within the 2-week timetable about psychological health and well-being, and they had scheduled times for relaxation and for mindfulness, and obviously physical rehabilitation as well. And there was a focus on pulmonary rehabilitation, also cardiovascular exercise, and also strength and conditioning. We've just got some fairly provisional data from our first few courses. This slide was made up a few weeks ago, but at that point we'd seen, if you look on the right-hand column here, 122 patients who have been in through their 2-week residential multidisciplinary rehabilitation course. 21% of them were of BAME origin, at mean age of 40. If we look at the pie chart down here, so some of the figures have dropped off there, but 70% were primary care or community patients, and 30% were hospitalised. And of those hospitalised, a quarter of them were intensive care patients, and 75% were just hospitalised to the ward. If we look at persistent symptoms, so if you look at the right-hand column, again, this is from our first 122 patients, some of the persistent symptoms were fatigue in 70%, shortness of breath on 1 flight of stairs in 68%, sleep disruption in 62%, and then headaches in 46%, and pain, which is often a kind of atypical chest pain, in 40% of our patients. From a mental health perspective, we track and record anxiety, depression, and PTSD. So from an anxiety perspective, from GAD-7, we had a range of between 28% and 62% having moderate anxiety. From a PHQ-9 and depression perspective, we had a range of between 33% and 87% having moderate amounts of depression. And in a impact of event scale, this is a PTSD scale, we had a range of 42% to 71%. We also set up a COVID recovery service, and this was really to look at in more detail medically the effects of post or previous COVID infection, and research. And these two services, if you like, the research and the COVID recovery service, very much interlinks and overlapped. Our particular research question with our population in mind is, what was the cardiopulmonary and functional outcomes of UK military personnel who has suffered from COVID-19? We really wanted to know how this was going to affect our population. Was it going to affect defence in the long term? And in particular, what you'll see in the top comment here in terms of our aim is we wanted to look at their cardiopulmonary and functional outcomes, but across the spectrum of disease. So in terms of our research study, we're looking at 80 people over at least a year. We're hoping to extend that to at least 120 people. We have hospitalised, and of those hospitalised, some of them are ITU, post-ITU patients. We also have a number of community-treated patients, some of them with ongoing symptoms, but some of them also without any ongoing symptoms, and we've got a small group of controls. And we want to do this research really to inform our military clinical rehabilitation pathway as much as possible moving forward, and also to inform the potential impact on UK defence. Are we going to have a lot of people who've had mild COVID, potentially thousands, who have real difficulties getting back to full levels of exercise, which in our population is important. This is a nice schematic that was designed by Lieutenant Colonel David Holdsworth, who's one of the cardiologists who's key both on the clinical side and the research side. And I'll just talk you through this because I realise it's quite busy, but essentially this happens over an admission from a Sunday night to a Wednesday. If you are entered into the M-COVID study, that's our military COVID study, then you have everything on this screen. If you don't want to participate, because clearly it's optional, then you have the clinical side, which is the top part. So they come in on a Sunday night. On a Monday morning, they'll have an ECG, they'll complete questionnaires, and those are the mental health questionnaires and other such questionnaires that I've already alluded to. Blood, spirometry, 6-minute walk test, CPET, so cardiopulmonary exercise testing, echo and cognitive testing. And we use the NIH cognitive batch for that, which is an online app. And then they go on Wednesday to Oxford, who are where David Holdsworth is based, and we're collaborating with Oxford to have lung function testing and arterial blood gases, exercise echo, CT chest, dual energy CTPA, and cardiac MR. If they are also in the M-COVID and sign up for that, which I have to say we're having a very good recruitment rate for this. I think patients are very interested to see what has happened to them. We do a laser gas analyzer, which is a research tool based at Oxford, which really looks at the matching and distribution of gas and blood in the lungs. A cardiac 31P MR spectroscopy, which looks at the mitochondrial dysfunction and energetics of the heart, and a brain MRI. So far, and these are essentially the clinical patients, but almost all of them have also come into the study. We've seen 30. It's quite time consuming, so we can only see 5 or 6 a week. 27 of them have been male, mean age of 42, with an average time of 5.5 months since their acute illness. And so far, 66% of them have been either PCR or antibody positive. We expect that will increase because testing is now more readily available. Of interest, about 45% of them have been healthcare workers or have lived with healthcare workers. And in terms of the abnormalities we're seeing, and again, I have to stress this is very provisional and I haven't got all the answers, so I'll do my best. 6 of them have had a lung function abnormality. 8 of them have had abnormal CPET. None of them have had normal CTPA. None of them had abnormal CTPAs, but 6 out of 22 have had some lung fibrosis on CT chest, as Philip was alluding to. We've had 2 abnormal cardiac MRIs, but we don't think that's related to COVID. And then from a functional and psychological comorbidity perspective, fatigue and concentration is a massive issue, and that has triggered 57% of our referrals onto the psychologist. We're also seeing a fair amount of anxiety, and that's triggered 17% of our referrals, and also depression, which has triggered 34% of our referrals. And then from the PTSD perspective, which is something that is recognised particularly in post-ITU patients, that's triggered 21% of our referrals. So that is the schematic of our recovery service and our M-COVID research study. And to emphasise, the research is going to carry on out to 12 months, although the testing at 6 months is going to be much more limited to CPET and 6-minute walk tests and questionnaires. We've seen 30, we've got at least another 120 waiting to be assessed. So in summary, I've just given you a bit of background about COVID, which you're all very familiar with, but it's a fascinating story, and talked about our rehabilitation service, our recovery service, and our research, which is ongoing, and our very initial preliminary findings. Thank you very much for your time. Back to you, Elaine.
Thank you, Alex. So already quite a lot of interest in both your presentation and Philip's in some of the question boxes. So we will move in a moment to the panel discussion. But before we do that, can we have our second poll? So we want to ask people about what sort of research questions we should be asking. So if you can vote on this, you can vote for more than one of these. Just wait a couple of minutes till everybody's had a chance to vote, and just to remind people, if you would like to pose a question for me to ask the panel, you can put it in the Q&A box at the bottom of your screen. So I probably shouldn't have given you a choice between all of them, but actually strong sense of doing prevalence studies, and I know from the long COVID support groups there's a lot of demand for that. And if we can move now into our panel discussion, maybe I should start then with a question that came very early on from Stephanie O'Donoghue, who said that many patients have raised concerns that the King's College Zoe app is limited in its ability to capture the full extent and prevalence of long COVID. Understanding long COVID numbers risks the service delivery and plans being grossly underfunded. Do you think there's an awareness of the limitations of the Zoe app? And I think we shouldn't pick on just the Zoe app. There's a number of people making estimates of long COVID, but can I start with Philip? Do you think how much weight should we attach to the small surveys that are telling us the prevalence?
I think so far it feels like we've gone, well, we think it's about this much, and there hasn't been a sort of systematic assessment of what is the prevalence of symptoms. Part of my concern with something like an app is that immediately excludes anybody who hasn't downloaded it, anybody who hasn't got a phone, anybody who isn't familiar with technology, which immediately confines the possible responders to a much smaller group than the population as a whole. It's useful insofar as it goes, but it's not. I don't think it's going to give you the kind of data that we need to make plans about whatever we want to call it, a long COVID service.
Yeah, and Alex, one of the things about the Zoe app is that they followed up patients who'd had a positive PCR. What's the challenge around restricting or counting to people who've had a positive PCR or antibody test?
Yeah, I mean, testing's been a massive challenge from the start, and clearly testing is getting better. I can just reflect on our own personal experience in that I think particularly those who have been admitted to hospital, it's more easy, and I've not been involved in the acute care, but from what I'm told, you can see a clinical pattern that is recognisable as a COVID illness, and those patients, maybe if they're not positive, then it's less of an issue. Having said that, they're also more likely to have been tested and probably more likely to be positive. I think it's very difficult in the community-based patients who've had more mild disease, who either haven't had the test acutely or have had acute illness which doesn't tick all the boxes, which I think lots of people recognise. It's a huge challenge, and I think there's not a right answer to it, because it's very difficult to write people off because they haven't got a positive test and say, well, these symptoms can't be related. But also we don't want to do vice versa and assume that everything that everyone is complaining of is due to COVID, which would really take us down a rabbit hole. So I think we just have to accept that there's been challenges with testing, and we need to use it as much as possible moving forward. We need to look at data which is clearly clinical data which helps define a case of COVID, and use that when testing is not available, and hope that the testing it gets better and better, and we can use that to define cases.
Thank you. One of the things that has been used to describe long COVID is very long lists of symptoms, and in fact the Zoe app had a smaller list of symptoms than some others. I wonder if I could ask Vanessa, from an occupational therapy point of view, how helpful is it to focus research or even diagnosis and services on individual symptoms rather than on the patient or the person's whole experience?
It's I can't actually turn my video on. It's controlled by the host at the moment.
Talking cat.
That's Polonius, he's a star. Thank you. So I think it's very. I think you just tweeted, or Derek Wade tweeted a article this morning, which I've retweeted, which is that it's not helpful at all. The integrated approach is very much what's recommended by ICF as well. And that with the sort of view that some symptoms are perhaps in people's mind, unless you bring it all together, it's very difficult to get an overview. And unless you have that overview, it's very difficult as a therapist to know how to focus your therapy as part of a team. So Alex's multidisciplinary 2-week program is amazing. It's got everything there and it will encompass all those different elements. However, if you're going through NHS standard treatment, you're I hesitate to say probably not going to get that.
Which does raise the question about the money that NHS England has put into COVID clinics. You know, are they the answer? You know, for any of you think they're the answer, or are they the beginning? Do we need something like Alex's 2-week rehabilitation program to follow that?
Well, I mean, the other thing is a lot of people who are going to have ongoing symptoms from COVID have other multiple long-term conditions. So if you separate your COVID rehab from your ongoing COPD, diabetes, arthritis, neurological diseases, how are you going to make sense of that?
Can I just make a comment, Elaine?
Yeah.
And just going back to Philip's WNL, we never looked. I think one of the things that we're trying to establish, because we realised that probably in our population we would have more mild acute disease, was by doing our recovery service and our fairly in-depth medical assessment, is whether symptoms correlate to ongoing significant pathology. And I think what would be very useful from that, and what we're trying to get out of it, and we're not saying it's a perfect study at all, it's very observational at the moment, but can you be, is it symptom driven? So if you have symptoms, does that mean you necessarily have ongoing pathology or not? I suspect that there's going to be a mixture there, and I think there's going to be quite a few people who don't have any ongoing significant pathology but still have ongoing symptoms, but I think it's going to help us perhaps untangle those with ongoing significant pathology and their pattern of symptoms with those perhaps without ongoing significant pathology and their pattern of symptoms.
I think to answer your question about are the long COVID clinics going to be enough, I think they are probably going to be necessary but not sufficient. That they are a start and a recognition that the COVID experience, if you can call it that, isn't just the acute admission. There is something ongoing. But if we are correct in our assumption that actually there are more people with ongoing symptoms who were not hospitalised, then having centres for post-hospital patients who had COVID won't be anywhere near enough to deal with the burden of symptoms that are out there.
And that raises an interesting question about the differences. So we've got questions from our audience from Gerard Coakley and from Charles about, I think they're about early interventions. So Gerard Coakley asks whether any plans to have an RCT of steroids versus placebo for patients with, well, in any of our subgroups, but I suppose as we're talking particularly about long COVID. And then Charles asking, what do we know about what we could do early on? Because at the moment we're picking up with people with long COVID months after they've had their first symptoms. What should we be doing now to identify and treat long COVID early?
Well, I suppose one thing that will be interesting, just observing what happens in the next couple of months while we're sorting out long COVID definitions and so on, is pretty much all the hospitalised patients should now be getting dexamethasone. So does that then change the course of the acute and post-acute illness?
So would we be giving steroids to people who were not hospitalised?
At the moment, the answer is no. Should we be, and is that a reasonable research question? it's probably a reasonable question to ask. I am off the top of my head, I am not certain whether anybody is actually looking at that at the moment.
Elaine, can I just make a comment to Charles's question?
Yeah.
And this is very anecdotal. Again, I'm sorry I can't back it up with the data, but also very much relating to people who have had more mild acute illness, and I think also in the early stages when maybe people didn't necessarily realise if they've had COVID or not. But certainly, I think there's a mindset amongst younger people when they've had a very mild viral illness to crack on with, a day or so later, crack on with their normal activities and normal exercise. And I think that with this particular viral illness, I think a significant period of rest, even after a relatively mild acute illness, is what we're recommending. Certainly going back to high level exercise within a few days of having a mild illness, which could have been COVID. I think what we're seeing, again, very anecdotally, is that some people have found that really difficult, and they're having these kind of and maybe it prevents their full recovery, and they're having these real peaks and troughs, and they need to perhaps have a more prolonged period of recuperation before a more gradual return to full activity and full exercise. But I'm afraid I can't back up with strong evidence at the moment.
Okay, we've got a question from Gemma Haynes, specifically for you, Alex, I think, about whether you saw any swallowing or speech problems, and whether you have a speech and language therapist on your team.
Yeah, very good question. So to answer the second part, yes, we do. And we have a speech and language therapist available. I don't believe that we have seen too much in the way of speech and language problems. I could refer to calling to Rob Barker-Davis, who's also on the conference, who is more involved on the clinical level, if you'd like to ask him. But I don't think we're seeing too much of that.
James, is it possible to give microphone access to Rob Barker-Davis?
He may be down. He may be down as his wife.
We won't ask.
Who is Kieran Bilku. But you may want to move on. Bilkhu.
Okay. Well, while we're thinking about that, I mean, I think that there is an issue about. Hello?
Can you hear me?
Yeah, we can. Go ahead,
yes,
Rob.
On my wife's computer, it's Rob Barker-Davis. So yes, one thing we started doing with this was with the recovery service was cognitive testing, and looking at a lot of the domains, and some of the areas people are complaining of is processing, and I think that may be feeding into a little bit of word finding difficulty. So we're currently putting measures in place, having identified that now, to work with our psychologists and within our neuro team. There's some overlap there with they work together very closely with speech and language. So it's something we're looking at.
But Rob, we're not seeing too much in terms of voice and swallowing, are we? Problems?
No, not so much on that side. Yeah.
Thank you.
Okay. So there's a question from Lynn J about paediatric needs, and one of the things that we also know, there was a paper out from Leeds University about long COVID in care homes and atypical presentations. They were saying people who had not had a history of falls, who were suddenly falling, they thought this was ongoing effects of COVID. So I suppose a question, and Vanessa might be well placed to ask this, about, are we thinking enough about the multidisciplinary needs and the needs of people at either ends of the spectrum and people with learning disabilities? I know we've had conversations in our steering group. There seems to be a lot of long COVID in people with learning disabilities. Are we doing enough at the moment to plan a multidisciplinary response and making sure we've got the workforce to do that?
I think the workforce issue is a huge problem, and maybe somebody in the audience might want to comment on that. I notice we've got one person from one of the trusts, KCHT, Lee Tomlinson, I think. In terms of the therapy being spread thin with staff off sick and those who have to self-isolate, to then increase therapy in care homes, I can't really imagine how that's going to happen, because it's always been a problem to have, for example, intermediate care going into care homes. And even just sort of the odd visit from OT or physio in care homes is usually difficult with long waiting lists. So I'd be interested to hear from people who are at a more strategic level within trusts how they think that's going to work.
Can I make one more comment, Elaine, on what? And again, you saw some of our data from our clinical rehab courses. What again anecdotally, but they seem to benefit very much from it. But I think predominantly from the education side. I think understandably with this condition, there is a huge amount of anxiety, and that is absolutely understandable. I'm not saying that's the only reason that's driving symptoms, but there is anxiety. The fact that they're listened to, that we give them lots of education about fairly straightforward stuff, but actually people don't have access to it in terms of pacing, in terms of nutrition, in terms of what are the complications you need to be looking out for. I think they generally, some fairly easy to deliver education makes a massive difference to the well-being of the patients.
And I think that ties in with a comment we've had from Jo House, who's actually one of the people living with long COVID who's been advising us. And she said, in the light of the range and symptoms and the need for prolonged rest and recuperation, do you think there's a need to update the government guidance for the general public on COVID symptoms, and what to do if you have continuing symptoms? So for all three of you, do you think we're giving enough advice for people, given there seems to be a significant number of people with long COVID, about how to self-manage it? So Philip, I mean, what your patients, what advice are they getting?
Short answer is no, I don't think we are. I suppose it's worth saying again that this is a new illness. It is not behaving in the same way as other infections, other viral illnesses that we've seen previously. So we are, all of us, running very, very fast to try and catch up. Yes, it feels like the advice needs to change, again, so that patients have a clear idea of that what they're feeling is normal, and actually that, yes, they may need a longer period to not rush back to work. And in particular, the kind of work that Group Captain Bennett was describing, with physical training instructors shouting at them every day.
I think it's really difficult. I think it's a very good question, and I think that it feels that there needs to be more advice out there, but it's very difficult to know exactly what advice to give, because you don't want to give advice which isn't properly data-driven advice, and you get the impression that people are nervous about giving advice without good data, but I think there could be improvements.
Yeah, and I think that's, people have made these comments in the questions from the chat box. That is a void that's being filled by the support groups at the moment. So maybe there's something about us working with people, and one of the things we try to do in the review is to give gravitas to the lived experience and what we learn from that. In fact, our next webinar next week will be on that. So there's a couple of people have asked questions about what research is being funded into long COVID, and some of you may already know that there is a large post-hospital study led by Leicester that the NIHR is about to advertise a joint call with UKRI into ongoing effects of COVID-19 in people who were never admitted to hospital. And I think the call for that is coming out on the 12th of November. We would be very, very interested if anybody can point us to other research that's going on so we can put it on our website in our review. But I think the general answer is the focus has been on acute of COVID, and we're only now turning our attention to long COVID. Question from Gerard Coakley. Can anyone on the panel advise what NHS England plans to do about rehabilitation post-COVID? From my perspective, it would make a lot of sense to use existing chronic fatigue syndrome ME services using the occupational health rehab approach. So I think I'll direct this one at Vanessa, but also raise the issue about, is it right to just assume that these are chronic fatigue syndromes that we're seeing in long COVID patients? And are there any dangers in making the assumption it is a chronic fatigue problem and therefore using that approach? So put you on the spot a bit there, Vanessa.
I think perhaps we're too early to make that call. However, and there are certain different views on how does it compare to chronic fatigue and other similar syndromes. However, I think we also need to take into account our staffing and our structures. If we have something set up that appears to be appropriate and that we can access straight away, that would seem sensible, at least as an interim measure until we have more research on long-term effects and rehab. And I think it'd be perhaps interesting, perhaps Alex, you might want to comment on the rehab beyond your 2-week inpatient as to what are the main sort of needs and do they accord with the chronic fatigue services? But bearing in mind that your service is probably a lot more comprehensive than a lot of other services.
I think we haven't had too many people who've been through the rehab and then had 3 months post. So we will see, but there's what the need is going forward. But I think that certainly there is some overlap in the symptomatology, but I think you're absolutely right. It's too early to say whether this is just a post-viral chronic fatigue syndrome or something else. But certainly fatigue is a big issue. It's the number one symptom that people complain about, and I think that there may well be a post-viral fatigue syndrome with this. But I think we need to see get more data and see how the outcomes of these patients a bit more.
I think following on from that, as I was saying, what we were expecting was that this was going to be a disease causing predominantly respiratory long-term issues. It feels much more like a multisystem disorder. Is it ongoing inflammation? What is it? But actually, the kind of people who deal with chronic inflammatory multisystem pathology are rheumatologists and rehabilitation specialists. So rather than a chronic fatigue service, then there may be a role for a rheumatology involvement in local services. That's a guess, that is not evidence-based, but I just wonder.
Yeah, and we've got a comment in chat books from Kiran Bhikkhu, I think we've now established is Rob Davis, saying that there's a lot of overlap with overtrain syndrome. Not quite sure what that is. I don't think I've ever suffered from it. Is that taking too much exercise?
Mm.
Exactly. Early education on pacing is important. I don't know, Rob, if your mic is still open, if you want to comment on that.
Yeah, so I mean, if I just list the symptoms of overtraining syndrome, which we do see in athletes who push and don't really perhaps quite understand the need to cycle their training and have rest periods or active rest periods, and those symptoms are things like muscle pain, joint pain, weight loss, appetite, increased heart rate at rest. A lot of people are complaining about with this as well. Decreased general performance, fatigue, prolonged recovery, lack of enthusiasm, changes in personality and mood and irritability and difficulty concentrating, and sleep disturbance. I think a lot of people are probably nodding on this and identifying with a lot of those. I suppose the message that we give, if elite athletes need to cycle their training and step back from doing certain things, then perhaps we all do. And perhaps if we do that early on, we can perhaps avert establishing a lot of the behaviours that may drive a sort of stepwise deterioration in the overall health status.
Okay, thanks. So we are coming to the end. We could go on having this conversation for hours, but we are coming to the end of our hour. So I'm going to use Chair's prerogative to ask a question. A lot of the things we've talked about have been services that are provided in hospitals or clinics. They may not be inpatient, but they're hospital-based. Surely the majority of people with ongoing problems are going to be based in the community. And given the workforce issues that we've alluded to and Vanessa has, do we need to think of a new type of worker in the community who can support people? Because we know there are some people in month 8 and month 9, and we're going into another surge. So we're likely to see quite a number of people early next year. Do we have to think more creatively about who is giving the healthcare support to these people?
Yes.
Longer, please, Philip.
Do you want something slightly more than that? Yes, I think we do. One thing that this pandemic has forced us to do is to think creatively about how we do our stuff, how we develop and deliver care, and however we do it. I think there is going to be a great need for thinking creatively about how we deliver evidence-based care for patients with long COVID or whatever we're going to call it.
Thank you. Alex?
Absolutely. I think we need, yes, in a word. I think that, community-based, if we just look at rehabilitation as a whole, community-based rehabilitation has always been something that's been stretched and has been a challenge. And I think that once we establish that medically people are they don't have ongoing kind of pathology, and they need more rehabilitation, then the community is the place to do it. And I would argue that it would have been even without a pandemic, it would be nice to readdress community rehabilitation in terms of funding. But I think with the pandemic, there's a real need to do that with some urgency.
The one other thought that I had in terms of how we do this, there is a sense of urgency to this. We could be talking about lots and lots and lots and lots and lots of patients nationwide. If we wait for properly constructed randomized controlled trials, this will all be over by the time we get something approaching an answer. So one other approach, sort of while we're waiting, might be to almost to take each patient as a quality improvement project and do rapid tests of change in a much shorter time frame to say, okay, what works for you? We have this this gathering knowledge. We have the evidence that we're getting. Okay, for you, if you rest for a period, does that help? Does that help the symptoms that you're getting? Going on from there, does a graded rehabilitation approach help? Using measures that are quickly and easily available and are reproducible over time, which of course is the other thing we need to look at, is what data are we going to measure to demonstrate improvement? Is it going to be something subjective that amounts to, hello, how do you feel? Or is it going to be something a way of measuring cardiopulmonary function over time.
Yeah. Interesting about quality improvement, because actually that hasn't been discussed a lot in relation with either COVID or long COVID. But if I can move to give Vanessa the last word on this before we move to our final poll. So Vanessa, you've raised a couple of times the issues about the workforce, and it clearly has to be a multidisciplinary workforce. We know the Nightingale hospitals were going to bring all sorts of people in, you know, fitness trainers, cabin crew from Virgin. Do we have to think that creatively to bring in people and train them up to help with this rather than registered professionals?
Yes, we need to be creative, and yes, we need to be community based. We also have a lot of workers in social care already who have a good grounding. We've got social prescribing, and we've also got our voluntary workforce that's done a lot. But I think it was Gemma's comment, is that people's needs change over time. And you've also got the complexity of who you're dealing with, from older people with multiple other long-term conditions to younger people who need to return to work and who are going to be struggling to find a job anyway, some of them. And that's going to lead to longer problems in terms of poverty and depression, and all the things that go with longer term unemployment and chronic conditions. So I think that it's very complex. So I'd be hesitant to give a yes, be more creative.
And very good points about the social impact of this. A lot of people who are of working age are finding real problems with lack of income and jobs. We are at the end of our time, but if we can just have our final poll, James. So this is really about what sort of services should we be providing, specialist COVID clinics, GP services, or should we be allowing people to use their professional judgment? So if you could vote now. So the specialist COVID clinics being the most popular, and the individual professional judgment less popular, but maybe that will change. I just like to thank our panelists very much, all very busy people, and got some really interesting insights. And I think for me, there was a lot of new information, so I've learned a lot. I hope the people watching the webinar have learned as well. Thank you to the people who've joined and asked questions. We will go back and look at the chat box and the questions and answers. And when we put this recording up online, we'll put some more responses to that. So it just remains me to say thank you very much to everybody, and have a good day.
Thank you.
Thank you.
Bye. Thanks.
Bye.
Thank you.
Bye.